No problem. The other thing I'm going to say right now to everybody is we're going to record these. And so because we know, like, 2 p.m. on Tuesday isn't necessarily like this magical hour when people just don't have anything better to do. So we've started recording these on Zoom, and we'll post these on the UNMC private YouTube channel and then share that link out to just the hospitals in the Capture Falls project. So if you want to listen in later, or if you're a hospital that just can't be here at this time, we'll be sharing that link to that YouTube recording out with everybody as well. Okay, so all right, well, welcome everybody. I'm going to go ahead and officially get started. So we are, this is collaborative call number 36 out of all the ones that we've been doing over the years. We decided to kind of get back to basics and talk about some things that we can do at the bedside to keep our patients safe. So that's what we're going to be discussing today. The agenda, if you're joining via computer, you should be able to see my slides on your screen. And if you are not joining by the computer, we sent out the handout of these slides via email yesterday. Okay, so we're going to go over a few housekeeping items today about the Capture Falls project, and then the bulk of the time is going to be spent looking at providing some education about talking about linking bedside interventions to patient fall risk factors. Okay, so just in the last few weeks, you should have been getting some emails from Janae Murray, who is our research assistant. She works very closely with Anne in the No Falls database. And so those two prepared quarterly data reports for Q2 of 2020 about your fall data. So basically anybody who's been reporting into No Falls should have gotten one of those. We encourage you to report into the No Falls database. It helps you learn from your falls over time. It helps us kind of create this large database of falls across critical access hospitals so we can kind of learn collectively from everybody. If you've had any staff turnover, if you have any issues accessing that or haven't been in it for a while and need a refresher on how to use the system, Ann Skinner is your go-to person, and so her contact information is listed there. Housekeeping item number 2, knowing that the fall event reports and No Falls, we realize that it's a lot. There's a lot of data fields that we request. There's this delicate balance between, it's like, okay, is it need to have information or nice to have information? We're looking at what do people, like places like the Agency for Healthcare Research and Quality, what are they recommending that people collect about their fall events? We're trying to balance all of that with the time and the burden we know because the forms are long. And so we've been working on the last several months, looking at the forms, trying to streamline them down. Our plan is to come up with some new forms. We're trying to reorder the information to make it a little bit more logical. We're going to be sharing a draft of that with you before we actually make any changes, because you are the end user. We think we know how you use the forms, but we want feedback from you before we roll out anything new. But we are taking some efforts to shorten those down because we know that's something we've heard from you guys loud and clear about that. Okay, housekeeping item number 3. Okay, we've also been working on some new additions to the Capture Falls website. So hopefully you're all familiar with our website. We are specifically adding a new roadmap section. And so this section is going to kind of map out step-by-step activities that your fall team should be engaging in to really create a strong and robust fall risk reduction program. And so we think this new section of the website will be especially helpful to anybody who's new to Capture Falls and kind of starting from scratch or trying to kind of reboot their fall program. If you're a hospital who's been in Capture Falls for a while and you maybe just need a little refresher, or you need to like, okay, are we doing the right things? It would also be a good place for you to go. And so that'll be a new section of the website that should be coming out sometime this fall. We've been doing a lot of vetting of information from other sources, of other reputable sources. And so for every step that your fall team might take, there are going to be resources, educational resources and tools for you to use to implement that. Vicky's been leading the charge on that revamp of that new section of the website. And so if you have any ideas about that, you can reach out to her. Certainly you might, even if, once it goes live, you might have additional feedback and ideas for improvement. And we're always open to that sort of thing, okay? All right, so that's the last housekeeping item. I'm just going to mention again that if you are here, if you will take a moment, if you want to use the chat feature of Zoom to type in the name of your hospital to let us know that you're here, or if you want to unmute, *6 if you're on your phone, or the little mute icon at the bottom of your screen to let us know that you are here if you haven't already checked in. Okay. All right. Well, then I'll go ahead and get moving on into the educational content part of our call today. And so these next two slides are really just, they look a little daunting. There's a lot we can do for our patients who are identified at fall risk. And so as I was creating this list, this is just alphabetical. This is not in any special order, but alphabetical. But slide 6 and slide 7 has a list of really almost any intervention you could possibly think of that we could do for our patients who are at fall risk. And it almost feels like a menu for the Cheesecake Factory. I was reminiscing about that back in the days when we got to go out to eat and not feel nervous about catching COVID. You went to the Cheesecake Factory and the menu was just daunting. And that's kind of what this is like. It's like, how do we possibly decide what we should do for our patients? And so that's what I'm going to talk through today is to try to take a step back and discuss, okay, how can we really link these interventions to risk factors that the patient actually has, okay? So we don't want to waste time. Our resources doing things that aren't necessary for our patients for sure. Okay, so here's the second half of that menu of options, okay? So we don't want to throw everything but the kitchen sink at the patient. We don't have the resources to do that. We don't have the staff to do that. You end up getting intervention fatigue because you're doing things that maybe don't feel like they're doing any good, okay? So you want to do what makes sense. So you want to link them specifically to your patient's risk factors and be more selective in your choices of interventions, okay? Now, that said, there are certain things that we definitely want to do for every patient. And so those are called universal interventions. These are pretty common sense things that we're going to do for every single patient, every single time, regardless if they're at fall risk. So, anybody, whether it's any patient at fall risk or not, or staff member or visitor, anybody can slip and fall if there's a spill on the floor that doesn't get cleaned up soon enough. Or if a patient's oxygen tubing is stretched across the room, that's a tripping hazard for everybody, not just that patient. And so these universal interventions really are helpful for more than just our patients and for any patient who is in the hospital. The hospital is a really unique environment. People aren't familiar with it. And so we kind of have to assume almost every patient is at risk to some extent, okay? These universal interventions focus largely on the environment. They also have to do somewhat with how the patients and staff interact with each other as well. Okay, so here's a list of the common sense, common universal interventions. And so just looking at this list, you can see a lot of things that are, let me get my laser pointer out here. You can see a lot of things that have to do with the environment, like making sure the floor is clean and dry, decluttering, good lighting, that sort of thing, okay? Some of it also, again, has to do with patients and staff interacting with each other. Patient-family education, purposeful hourly rounding, making sure that the staff has the patient's belongings and call light within reach every time that they leave the room. All right, so now we're going to get into being more selective and making sure your interventions match the risk factors that your patient has, okay? So this is going to be part of our new roadmap on the website. It is going to be talking about how do you link interventions to the risk factors that a patient has. And so these are the risk factors that we've chosen to highlight on the website. These are things that are common regardless of what tool that you're using, whether your nurses use the Morse, or maybe they use the FRAS, or maybe they use the Johns Hopkins Fall Risk Assessment tool. These are things that are common items on those tools, okay? So you know, how do you know your patient has these risk factors? Well, that risk assessment tool is going to tell you that. And so a lot of times I think people get so worked up about, okay, well, if they score a certain, you know, if they're below this certain score or above this certain score, depending on how the scale goes, okay, they're at high risk for falls. Here's the bundle of interventions that we want to give that person. So that's all well and good. And in some cases that's easy from a policy standpoint. But I would also recommend that you take a look at what the actual items are that that patient is failing on that tool. Okay, so like if polypharmacy is an issue for that individual patient, regardless of what score they get on the tool, looking at interventions specifically to address that specific risk factor are what you should do. If it's identified that that patient has difficulty with mobility or ADLs, then again, it's interventions that are going to be directed at that particular risk factor that are going to give you the most bang for your buck. It's not just like, oh, let's slap a bed alarm on everybody. Not everybody needs a bed alarm, okay? So it's just being a little bit more judicious with your choice of interventions based on what items are identified on that fall risk assessment tool, okay? It might not even be identified on the fall risk assessment tool. It might just be based on your clinical assessment of the patient that you identify that they have certain risk factors for falling. So I just want to stop here for a second and see if anybody just has some initial thoughts about this list of common risk factors. Are there things that, does anybody see a gap? Are we missing a risk factor? You know, on a given assessment, it might not be worded exactly the same way. Like the item on the tool might be incontinence, where I'm calling it toileting needs a little bit more broadly. But does anybody see a gap in any of these risk factors that we have identified? Okay, well, hearing none, must be thorough, so I guess that's good. Now what we have is, I'm going to have several slides that are going to list like a menu of interventions for different risk factors. And when we set up our website, there's going to be like a page for interventions for cognitive and emotional impairments. And then there'll be some information on these interventions on how do you actually do them, especially if there's like more to it than just like, you know, putting the patient close to the nurse's station. I'm like, that's not rocket science. You do that. But like purposeful hourly rounding, there would be like sample policies that you could implement. There would be documentation tools to make sure that that is getting done. And so when there's like tools or education that would really help your hospital implement that intervention, that type of information will be made available on our website. So this is a list of items that are appropriate for patients with cognitive or emotional impairments. In no way do I mean to say that every single one of these needs to be done for every patient who's identified as having cognitive or emotional impairments. These cognitive or emotional impairments might be longstanding. It might be, you know, the patient has Alzheimer's disease and that's been a longstanding problem that patient has been dealing with. But sometimes there are also acute changes. Sometimes it's a medication side effect. Sometimes it's delirium because of an infection that they have. So obviously you kind of have to, you know, if you can treat the underlying cause, but in the meantime, what can we do to compensate for that impairment that's causing that risk factor? So that's what these are really geared towards. And so it's a lot of these you'll see have to do with increased supervision, okay? You might also recognize that one of the interventions, like purposeful hourly rounding, that's one of the universal interventions. It's also highlighted here as an important intervention for patients with cognitive and emotional impairments. And so those interventions are going to be potentially useful for multiple risk factors. So some of them you'll see those interventions show up and you'll be able to hit multiple risk factors for those interventions. Okay. Here's a list of interventions that I've kind of created for difficulty with mobilities or ADLs. This is definitely in my wheelhouse as a physical therapist. And so Lots of good information here. You know, medication review by pharmacy. This is another one that shows up on almost every single risk factor because of the side effects that medications can have that can impact cognition, that can impact mobility. So again, just like cognition, some of these issues might be kind of long-standing impairments that the patient has. Maybe they're having difficulty with mobility or ADLs because of a recent illness or injury as well. So it could be a chronic issue, it could be an acute issue. But again, a lot of these are either kind of directed at compensating for that impairment, physically assisting the patient, providing them with some supervision with those tasks as well, and maybe trying to rehabilitate the underlying impairment. That's what, you know, OTs and PTs would do largely in our intervention. Medications, you know, obviously any medication that's prescribed is intended to cause a positive change in a patient's medical condition, but we all know that there can be some pretty bad side effects as well that increase patients' risk of falls. And so these side effects might include something like sedation, cognitive changes, urinary or gastrointestinal effects, and orthostatic hypotension. And so that's kind of why that orthostatic blood pressure monitoring is listed specifically as an intervention here. Because again, it might be a change in med needs to happen or a change in dose, for example. Polypharmacy is also definitely a problem. Pharmacists are going to play such an important role in addressing this issue with your patients. And so it's really important to get them reviewing those medications, especially if it's identified that they have multiple medications or if they're on certain classes of medications that cause some of those side effects like the sedation, the impaired balance, weakness, orthostatic hypotension, and so on. You know, so there's those certain classes of drugs that are more problematic than others, especially for older adults. Okay. The next list of interventions has to do with risk of injury. And so this kind of is going to have its own page on our website. So despite our best efforts, some patients are just going to fall. And we have to be mindful of whether or not they're at increased risk of injury. And so the ABCs is a great way to think about this. And so A standing for age, people who are older are at higher risk of injury. B stands for bone. Anybody with osteopenia or osteoporosis are going to be at greater risk of fracture. C stands for coagulation. So if a patient is on anticoagulants or has some sort of blood clotting disorder, they're going to be at greater risk for bruising or internal bleeding. And then the S in the ABCs is for surgery. And so that again links back to the anticoagulants that are often prescribed. And also just thinking about having an incision or something like that kind of split open if a patient were to go down. And so some of these interventions listed here have to do with attenuating force if a patient were to fall. So making sure the bed's low, bedside floor mats, hip protectors. Medication review by pharmacy is important for the coagulation issue. And then toileting needs to be supervised in these patients because the bathroom is, a lot of research has shown that the bathroom is a dangerous place for patients to fall. There's lots of hard surfaces, it's a tight spot. You know, that's somewhere where we really need to be mindful of protecting our patients. Okay. Sensory impairment is the other risk factor category that we can have an impact on. And so if patients have impaired vision, vestibular sense, or somatosensation, like the feeling in their feet or their position sense of their joints, their balance and mobility is going to be impaired. And so a lot of the interventions here that you see are going to address that. Sensory impairment, such as hearing or vision loss, can also impact our ability to educate that patient effectively. And so making sure that we're having, you know, glasses on, if we're giving them reading material or hearing aids are in so they can understand the conversation we're having with them to educate them. Those can be considered fall risk reduction interventions as well. I want to also highlight OTs on this particular slide. Some OTs have special training in low vision rehabilitation. And so if you have a patient with that issue in particular, you might want to reach out to the OTs on staff to see if they might be able to be of help and have some tools available to make that better for patients. Okay. And then toileting needs. Everybody's got to use a toilet. And so this is, again, a common issue. A lot of falls surround this type of daily activity. And so maybe it related to issues of incontinence or urgency with bowel or bladder, mobility issues that make it difficult to ambulate to the bathroom or to transfer on and off a commode or a toilet. And again, these might be longstanding issues. They might be acute changes because of the patient's medical status or medications that they're on. So a lot of the interventions here you see listed are going to kind of proactively try to address toileting needs, like with purposeful rounding, or you might need to use some equipment like a commode or a handheld urinal to maybe temporarily avoid the need to go all the way to the bathroom. I do want to highlight PT on this slide because some PTs, just like OTs, have specialized training in low vision. Some physical therapists have specialized training in pelvic floor rehabilitation. So that might be something that a patient needs to be introduced to if the issue is more musculoskeletal in nature versus the side effect of a medication or a acute medical issue that's causing the issues with incontinence of bowel or bladder. Okay. A couple other common and common sense interventions that are really kind of across the board regardless of what the risk factor is that we should be using is making sure we have visual identification of a patient's at fall risk. And so this isn't, again, linked to any specific risk factor. This is just something you would do for everybody who is identified at risk. And so the bracelets, the socks, the colored gowns, the falling star, the falling leaf sign, whatever it is your hospital uses, you need to make sure that any staff member that walks into that patient's room knows whether or not that patient is at risk for falling. And then also handoff tool. So handoff tool, making sure that fall risk is discussed when you're handing off between shifts, and then also when you're handing off between departments, okay? All right, I'm gonna pause here again and just see if there's any initial reactions or thoughts. Am I missing any interventions? Are there interventions there that maybe don't make sense for the risk factor that I've linked them to? Any initial thoughts or comments from the audience? Okay, well, hearing no feedback, hopefully that means I'm on the right track and I'm not missing anything and that what I'm saying makes sense. All right. Now I do want to kind of finish up with the educational piece of this call with some comments about research about our interventions. Okay, so if you actually go to the PubMed and search for research literature about interventions for hospitalized patients, you're not going to find really that favorable information, unfortunately. And so I went to a couple of review articles, and so review articles are great because they summarize recent literature. You don't have to necessarily go to the individual articles, the original articles. You've got some authors who kind of are compiling the information for you, and so if you're kind of tight on time, they're just going to be a nice, efficient way. And so these are a couple really recent review articles that I came across. The first one listed on slide 19, if you're following along on paper, is from the Cochrane Library. And so the Cochrane database of systematic reviews is a really reputable place to find systematic reviews. They have groups of people that do these reviews on certain topics, and they update them every few years. So there's constantly updates coming out to these reviews. And a systematic review is a very non-biased way to summarize existing literature. And so they have set inclusion and exclusion criteria for what articles they're going to include. So they can't just find articles that kind of match their agenda, that the story that they want to tell. And they summarize everything for you, okay? And this other one I like, this LaRuin article is nice because it talks about some of the challenges with research evidence in this area, okay? But if you look at these two review articles, the interventions listed on the slide are the ones that these review articles specifically mention, and they say like, there's inconclusive evidence of any of this works, which seems really disheartening, okay? But I wanna get into why that might be the case, okay? So why is our research inconclusive, okay? So it's really difficult to design a strong, controlled research study on this topic. So hospitalized patients, they're not lab mice where we control everything about them. We control where they live, what their diet is, what kind of interaction they get. You know, we're talking about a hospital here. So there's a lot of moving parts. It's multifactorial. So a randomized control trial, or an RCT, is a gold standard for determining if interventions work. So you need a control group and you need an intervention group. And so the control group is going to get maybe a placebo, or maybe they get standard care. And then the intervention group is going to get whatever's new and better that we think is going to be better, okay? Everything else about those two groups ideally is the same. So it's the same kinds of patients, they have the same staff, you know, the same hospital setting, you know, ideally everything is the same. And if it's not, it's a potential confounding factor, okay? So if you do an RCT and say you're comparing intervention A and intervention B across two different hospitals, there's a lot different about those hospitals. The patients might be different, the staffing might be different, the culture might be different. So some people are like, well, let's do two different units in the same hospital. Well, that's still different. You know, it's different patient case mix. The staff is different. So maybe there's other quality improvement initiatives going on at the same time, and maybe they're different between different floors or units in the hospital. So sometimes researchers will do what they call a historical control. So let's look at your fall rates, you know, over 2 years with nothing, and then try the new intervention. Okay, well, even over time, things are going to change, you know, in terms of, again, the hospital culture, other initiatives, staffing, and et cetera, et cetera. So it's just really hard to do what's considered the gold standard for determining if an intervention would work. So a lot of the research evidence that we have is considered lower level on the evidence hierarchy. So it kind of really boils down to like a lot of case reports. And so when these review articles say, oh, the evidence is inconclusive, it's because they don't have these really strongly designed RCTs that they're able to draw from, because it's just almost impossible to do that with this particular problem in this kind of a setting. So I just want to mention that, because it's not like, oh, we should just like stop doing everything that we're doing. The other thing I will say is that research isn't the only thing that we should consider when we're practicing in an evidence-based fashion, okay? Hands down, we should keep an eye out for new evidence and stop something if there's strong evidence to say it doesn't work or it's even harmful. Be willing to change. But evidence-based practice really includes three things. It includes the best available research evidence, which is just the strongest research that's out there. Maybe that's not an RCT. Maybe that's at best a case study. That's okay. Maybe it's your own data that you're drawing from as well. Clinical expertise, you know, what makes sense clinically to do for a patient is a piece of evidence-based practice, and then patient values and preferences. And, you know, ultimately, people have some say in the care that we give them. And so those three things together should be informing our decisions when it comes to decisions made for individual patients, or when it comes to decisions made for policy. And so I guess I just want to say, like, yeah, don't be too disheartened. Like, I'm not saying like, oh, we should stop doing all of this stuff because there's not strong research evidence for it. It's like, well, evidence-based practice is really weighing all of those things. Okay. So we are at time already. I can always talk, Paige knows this, that I can talk forever about research. And anybody who's one of our UNMC alums in the PT program knows I can go on and on and on forever about that kind of stuff. But I guess, does anybody have any other thoughts that they want to share? Crowdsource some ideas from the group? Any comments? Nobody wants to be that person that keeps everybody on the phone or in class longer, so perhaps nobody will say anything. Well, certainly if you have anything that you think of afterwards, here's our contact information. So on slide 23, we've got our contact information. If you have any thoughts or feedback that you want to share with me about the interventions and linking them to those risk factors that you heard about today, please definitely reach out to me as we're kind of making some final tweaks to get that up on our website. Anything related to no falls, again, should go to Anne. Anything related to team performance implementation, you know, the industrial organizational psychology piece of it, Vicki is your person. If you're not sure, we have our general email address as well. And future collaborative call will be held in late October. So topic right now is still TBA. We kind of just, you know, kind of determine what that is. If somebody asks us a question, a lot of times we'll do the topic on that, or if it's just something that we think maybe hasn't been visited for a while. If you have any ideas, we're open to that, of course. So with that, we'll just stay on for a few more minutes if anybody does want to hang out and chat a little bit. Otherwise, if you haven't already signed into the chat that you're here, or if you want to unmute and let us know that you were here, that would be great as well.